We were just getting started. We're waiting for a few more people to log in. So I can just welcome everybody to today. Thank you guys for being here. It's fantastic to have everyone here. Dan, I was going to introduce you, but maybe you can introduce yourself even better than I can introduce you if you would like to, or I can give you a little introduction.
No, I'm happy to do that. I mean, it's a pretty straightforward story. I'm a plastic surgeon mostly focused on reconstructive surgery. And actually, an area of particular interest to me was pain after chest surgery, in large part because I was seeing so many people coming to me with submuscular implants and chronic pain. And it was actually now, I think it was about 14 years ago, I started doing implantation for reconstruction over the muscle. And at that time, that was considered blasphemous. But within about 2 or 3 years, a quarter of my practice was patients who were coming in to have submuscular implants converted to premuscular implants. And now prepectoral reconstruction, of course, is pretty much a new standard. So it's an area that's kind of near and dear to me. I am not a physical therapist, and so there's a lot of things here that you're going to know much better than I do. But I sort of give you my own understanding and sort of way of trying to categorize certain findings and how I might think about them.
Awesome. Thank you so much. Welcome everybody a little bit more. I'm Zeina. For those of you who don't know me directly, I have Synergy Plus Physical Therapy and Pilates Studio in San Rafael, and now a little satellite in Switzerland. And that's where I am currently. I'm in the Italian part, not the Swiss German part. We're a different breed over here. So if you haven't made it, you should come out. This topic came up to us. We have a group that meets every Wednesday. We talk through case studies and problems and typical issues that we see coming up that walk into our Pilates studio or into the physical therapy clinic. And so we bring in experts when it's outside our scope or we want to learn more about it. So that's how we got with Dr. Daniel Jacobs. We're super excited to have him here. And we were just going to have a little bit of a discussion about exactly that, breast reconstructive surgeries. And I just thought before we get started, just to know who our audience is, if you guys could just raise your hand, who here is a Pilates instructor amongst us? Those of you who are sharing your videos. Yeah, great. And what about physical therapists? I know Suzanne, you're here. Hi, welcome. Yes, great. Lisa, nice to meet you. And Sarah, yeah. And then what about anybody just a Pilates enthusiast here with us? No, okay. And anyone, yeah, great. And then anyone just here because you're interested in learning more about this topic? Yeah, awesome. Well, welcome to everybody. We're super glad to have you all here. And so, Dan, I thought maybe if you want, I have a whole list of questions for you, but I can let you speak a little bit ahead if you like. And just kind of give us a little more background. How we came specifically to ask you to be here in our small group was because we just wanted to know more about what options there are available for reconstructive surgeries, who are the people that you're seeing for those surgeries, and starting there. So I can let you take the reins, and if you need any prompting, I'm right here. So,
no worries. No, I put together a few slides to just sort of.
Awesome. Okay.
I read through some of the basic questions that Zeina had put together for this talk. And, you know, the truth is there's an endless number of different procedures that are performed in that large category called breast surgery. But I think it's pretty easy to kind of categorize this. Are we talking about implants? Are we talking about over the muscle and under the muscle? And are we talking about cosmetic or reconstructive? Those really are the three questions that kind of set in motion the types of problems and opportunities that exist with breast surgery. And of course, you know, with cosmetic or reconstructive, often when we're talking about reconstructive surgery, we're talking about after mastectomy. And so there's a post-mastectomy syndrome, which can come into play that obviously wouldn't come into play or wouldn't typically come into play for cosmetic procedures. So this is how I think of it when I'm dealing with problems that are associated with breast surgery. And then we can just kind of divide it up with what actually happens when you perform surgery on the breast, whether it be for reconstructive or cosmetic purposes. And this is the basic innervation of the breast. You can see there are a lot of lateral and medial intercostal nerves, and all kinds of surgical procedures can transect one of those nerves. And if you transect them, then you can get what's called a neuroma, which is essentially, when you cut the nerve, it tries to grow out and find a target. And that growth at the end can become large and incredibly sensitive. And usually the way that you would identify something like that is neuroma pain is usually continuous. And oftentimes what you'll do is you'll try to inject one of these nerve branches and see if that makes the pain go away. And that can be a good clue that you're dealing with a neuroma. And that's a different pattern typically than what you would see in muscle pain that's associated with submuscular implants. And here you can see in order to get an implant under the muscle, you have to release a portion. And so every time that muscle contracts, this part goes up towards the shoulder. And that's why you also sometimes in the gym, you can sort of tell who's had a submuscular implant because there's so much motion in the chest when the pectoralis muscle contracts. But in contradistinction to a neuroma, this is likely to hurt more when the muscle is contracting. Whereas a neuroma would be relatively unrelated to muscle contraction. And then when we get to implants, exclusively, one of the areas of, probably one of the most common areas of pain with implants is capsular contracture, where the body forms a scar around the implant and that scar contracts. And I have to tell you, I'm not exactly sure why that hurts, but it does. It's not like a muscle is transected or a nerve is transected, but for some reason, as this capsule contracts, it's not that the implant gets hard, it's that the capsule is trying to compress liquid. Liquid is uncompressible, so it gets firm and painful. And I'll just kind of lay it out right here. I don't know that there's a role for physical therapy in capsular contracture. I think you pretty much have to just treat the condition. And then lymphedema, which in some ways has become almost exclusively the realm of physical therapists. I think that at least in the world that I've seen, the people who are taking this to a new level are it's plastic surgery and physical therapists, plastic surgeons, and trying to reconnect some of these lymphatic channels to the venous system, and the physical therapists who are becoming the real sort of trailblazers in diagnosis and pre-diagnosis as well as treatment. And here, this would only be for reconstructive surgery. There's no reason in cosmetic surgery that you should be dividing the branches of the lymphatic system that go to the arm. And so you really have to, if you see a patient who's had cosmetic breast surgery and lymphedema, you really kind of have to wonder if something else is going on. And of course, this is the progression of lymphedema in a graphic form. The other one that I think that you're probably pretty likely to see if you're dealing with especially breast cancer patients is frozen shoulder. And I don't know that there's a more empowering problem to treat than frozen shoulder, because so often it is so treatable. But it for, as you can imagine, for a variety of reasons, whether it be pain or apprehension, or the combination with radiation therapy, loss of shoulder motion followed by frozen shoulder at one level or another is not uncommon in especially breast cancer surgery. So where, at least as I understand this, where can physical therapy really make a big difference? I mean, lymphedema for sure, and both in prevention and treatment. And now, although I'm since in the last year and a half, I'm doing exclusively gender surgery, but I had a large cancer reconstructive practice, and anybody who was getting lymph node dissection and radiation, I would send to physical therapy before they got lymphedema. And so I think this is just a huge area. Really, like I said before, the trailblazers are the physical therapists and the plastic surgeons that are reconnecting the lymphatics to the venous system. Frozen shoulder, you know this one better than I do. Big opportunity. And then the muscle dysfunction that's associated with post-mastectomy syndrome is another huge area for opportunity. Where I don't typically see a lot of benefit from physical therapy is capsular contracture. And I know there are different protocols that some people try, but that just hurts. And I'm just, like I said before, I don't really see how you make that go away other than by releasing some of that pressure. Same thing with neuroma, and then the pain associated with submuscular implantation. Other than just that the global approach to pain, I'm not sure what role there is for physical therapy, and be curious to hear your thoughts on that. So Zeina had specifically asked, what are the restrictions in terms of physical therapy for patients who are post breast surgery? And other than the potential lymphedema patients, by the time any other patient gets to you, I can't imagine any restriction. And it should really be, if anything, just the opposite. Maximal attempt at recovery of range of motion and strength. And it's hard to think of anything that could go wrong, the months after surgery that would require some type of care or restriction in that setting. And then, what are the key goals here? Again, as I said before, I think you know this better than I do, but recovery of strength and range of motion. And the reason why I put focus on progress is, as I'm sure you're aware, the recent progress in chronic pain is less about the anatomical issue and more about sort of the psychological empowerment of how do you overcome, how do you sort of beat the pain, which is, you can almost say it's not part of you, it's a part that you have to overcome. And I think this is sometimes easier said than done, to be sure. But for whatever it's worth, I'll just tell one personal story. I had a total meniscectomy at age 16 from a ski accident when, long before the days of meniscal repairs. And so by the time I got to medical school, I was already having real problems with knee pain. And it was sort of before this era of what you might call empowerment over pain or something like that. But there were no good procedures, and there was no way I was going to get a knee replacement at 25 years of age. And my knee was stable, right? So I realized that there was no anatomic challenge that my knee had. All I had was pain. And for some reason, I just said to myself that since I can't have surgery, I'm either going to be forever limited by this, or I'm going to just defeat it. And I started doing more knee exercises, almost like, quite frankly, classic physical therapists would probably suggest. But I just said, since I know that I don't have an anatomic abnormality or instability, it's just pain. And if it's just pain, I'm going to overwhelm it. And here I am 40 years later, I have the same knee, and I'm actually pain-free. I'm sure I have more DJD than I did when I was 25 years old. But this whole new era of attempting to change the way we process pain, I think, is absolutely fascinating. I'm sure you know more about it than I do, but when I talk to my patients, I can at least tell them the story about my knee. So that's sort of what I put together, and I'm happy to try to answer any questions or tell you what I don't know. Oh, here, now I can see the column.
Thank you so much. So there is a question in the chat from Lisa. She asks if there's a differentiation between nerve pain and post-mastectomy syndrome.
That's a great question. I mean, they probably are one and the same. Whether it's a distinct neuroma, it's generally considered to be a neuropathic pain. What's very interesting, I have to share with you, what's very interesting in this whole world of, thinking of pain as a multidimensional diagnosis. Mastectomy for gender surgery has a very low rate of post-mastectomy syndrome. In fact, I've never seen it. And so it raises that fascinating question of the multidimensional aspect of pain processing.
Okay. Gina, are there any other questions in there?
So it looks like I see a couple of hands. So I saw Chris's hand up earlier and just wanted to check in to find out, Chris, if you still had a question or if it was addressed in the talk so far.
My hand actually accidentally went up. So.
Oh,
There's shoulder range of motion.
So then Sarah, I think, is next. And go ahead.
I had a scleroderma patient that developed it because she had, and then she died, obviously, but her implants had burst after a car accident, and they were made of silicone. What are they made of now, the implants?
It's still silicone.
Okay.
For many years, saline was used as a sort of placeholder while the FDA was reviewing the silicone implants. It's very interesting. Outside of the United States, silicone is injected freely into soft tissue mostly for cosmetic purposes. And in the United States, we sort of have a freakish approach to silicone that is not, clearly related to science. I think we've created a certain amount of hysteria around implant fractures. But I don't know, when I hear stories like you're describing, I frankly don't know what to do with it. Was it a silicone impurity from an old implant? Was it something else? But
yeah, it was just back in the day, in the 90s. It was all kind of new. So maybe they've changed the content or what's inside the implant. I don't know.
If so, it would just be the impurities. And
yeah.
Right now there's this huge controversy, as you probably know, around breast implant associated disorders. And on the one hand, it's really hard to ignore the fact that so many people are affected. And on the other hand, it has been a real struggle to try to understand what's going on.
Yeah.
And what, especially, like I said, when you look at medical standards around silicone outside of the United States versus in the United States, and certainly in Asia, the silicone is used like water. It's used for nasal augmentation, lips and buttocks, and so very hard to really get a handle on what actually is at what are the mechanisms that are going on with that.
Okay, thank you.
Great, thanks, Sarah. And in the chat, Dr. Jacobs, Katza asks, for someone who has had a total bilateral mastectomy and submuscular implants 9 years ago, would you recommend the reversal to prepectoral reconstruction?
So obviously the question is, are they having chronic pain?
So Katza, I don't know if you feel interested or comfortable in chiming in. Oh, it says no in the chat.
Yeah, so I wouldn't do it just to go prepectoral. I would, for someone who is having chronic pain, then it's not a major surgical endeavor to go from under the muscle to over the muscle, and it is often remarkably helpful. But if everything's fine, I'm one of the first people to say that if you're feeling fine, stay away from doctors with sharp objects. But if someone is having a lot of discomfort, then this can be a potential solution.
anyone
I
else
might
have
just
questions?
go
Sorry.
ahead, Chris, and then I'll tag on. Yeah.
Hi, Dr. Jacobs. Thank you for this presentation.
Sure.
I have a client who had subpectoral implants post breast surgery mastectomy. And she has a range of different symptoms, and I know there's the obvious stress on the pec muscle, but I'm wondering about pressure on the heart, pressure on the lungs, pressure on the rib cage, if there's other symptoms that you find with the subpectoral implants.
Interesting question. I mean, you really should not. It would be a surgical misadventure if you were actually involving an intercostal nerve, the nerves running between the ribs. You shouldn't normally be in that plane of dissection. So assuming that that wasn't the situation, it's, everything's possible in medicine, right? But it wouldn't be a typical or explainable cause of symptoms. The rib should completely separate the lungs and heart from the implant, and it would only be, the only thing that would make any sense really would be the implant causing some pressure on the ribs themselves. But that's not usually a very tender and anatomic structure. And so it's, my guess is if they're having chronic pain, it's either capsular contracture or the muscular dysfunction associated pain, or as we started, with the neuroma type pain.
There are a couple more questions in the chat, but Zeina, did you have something to add, or were you curious?
Go ahead. I'll fill in. Yeah, I'll fill in after. Mm-hmm.
Okay, and the next thing in the chat, Suzanne says, thank you to Dr. Jacobs. And could you address how capsular contractures are addressed, please?
Well, I'll tell you how they're not typically addressed anymore in the standard of care, which is to try to rupture the capsule, which is something that was done years ago, that apply lots and lots of pressure and try to literally burst the capsule so it could no longer constrict the implant. And so for all intents and purposes, the only effective treatment for capsular contracture is to remove the capsule. Now, the next question is, how do you prevent it from happening again? And there are some medications that, some of the asthma medications that doctors have tried over the last decade or two that may or may not really work. It's sort of it's not a huge effective intervention. But what is exciting is this whole category of devices called ADM, which is acellular dermal matrix. These are basically it starts with human transplant tissue, which is the dermis of skin. It's also taken from animals, especially pigs. But what it serves is a scaffold. And so you wrap the new implant in one of these sheets of ADM, and the tissue grows into it. The patient's tissue grows into that dermal matrix, and it tends to protect the patient from capsular contracture. That's the biggest advance in the last, really 50, 60 years of implant surgery. And it used to be incredibly frustrating. You'd remove the capsule and 4 months later, it would be back again. And now the rate of recurrence is much less because of that. So to answer your question, I think in terms of treatment, it's capsular removal. In terms of prevention, it's putting in a layer of one of these matrices that tends to protect the patient from recurrence.
Thank you. Kotz asks, what Pilates exercises should be avoided or recommended?
Yes, I'm not really an expert on Pilates.
That might be me answering that question. And I think I'm going to say really generally at the moment, but I think it depends a little bit on what you're seeing symptomatically. So Dr. Jacobs mentioned that they're really, by the time they're coming to us, they're not having any contraindications really to movement patterns. So it would be looking at where they're lacking, which I find is typically abdominal strength, pec opening work, and then shoulder range of motion work, more mobility at the initial stages, and then strengthening coming in right after that. But we will actually be going over this in 2 weeks' time, and actually demonstrating some of the Pilates exercises that could be useful, so that I can help assimilate some of this information. So we'll definitely invite you to that, so you can get more on that if that is interesting to you.
Thank you. I see Lisa and then Marilyn with questions. Lisa, if you want to unmute yourself, please feel free.
Yeah. Can you hear me?
Hey. Yeah.
Okay. I have a question, and I hope this is still within the scope of this conversation. You said that you don't think that there would be any range of motion restrictions or mobility restrictions, and I just want to get some clarification on that. Would that be for someone who is just having a cosmetic, not what do you call it, over the pec implant, versus someone who's had a mastectomy and maybe radiation? I'm just dipping my toe into trying to understand sort of what the process is that a person would go through. And I'm assuming that there's going to be some challenges with the quality of tissue, particularly if they get radiation, but even not really understanding the scope of what a full mastectomy would look like. Is there some scarring that we would have to address, and try to make sure that we wouldn't get any, I guess, compromise to the surgical site before going into a larger range of motion?
Yeah, no, I understand the question. And to be sure, postoperative regimens are all art and very little science. And so I'm only speaking for myself, right? I wouldn't try to speak for other surgeons on this. But as I said before, by the time somebody gets to you, which presumably is months after surgery, right? Unless it's a lymphedema prevention patient. It's hard to imagine how you affect the surgical site. The only example I can think of where somebody might squirm a little bit is if you have a known ruptured implant, then you could argue that you shouldn't put a lot of forces on it. But if it's a submuscular implant, there's a lot of forces on it no matter what you do. But I think maybe just in terms of just protecting yourself from liability, you wouldn't want to be the one to prescribe or to suggest, maximal forces on that implant. In the absence of a ruptured implant, again, just speaking for myself, I can't think of a surgical restriction. Obviously the patient may have restrictions on how much range of motion they have, but I wouldn't be the one saying that we shouldn't lift a certain amount of weight, or we can't go to a certain angle of deflection or anything of that type. It would be whatever you can help the patient achieve.
So I'm sorry, but before we go on, I wouldn't assume it would be months that I would assume that I could potentially see a patient 1 or 2 weeks after. So that's why my question is, why are you saying that it would be months? So then from what you're insinuating, there's a reason why they wouldn't go through range of motion or something up until that point.
So this is just a practice pattern, right? I have never seen in my own practice or my colleagues' practice where they routinely send immediate postoperative patients to physical therapy. That would be if that exists, that would be different. Because it does take several weeks for the surgical site to stabilize.
That was my question. That's
then that's going to be surgeon dependent, right? That's really going to be much more touchy than someone who's, say, 6 weeks or beyond, where the surgical site is quite stable by that point.
Okay, thank you.
Thanks so much, Lisa. Marilyn, you can unmute yourself if you're ready.
Yes, thank you. I'm a Pilates teacher. I have a client who has had a breast augmentation, and that one side is painful, but the other one is not. And it's not constant. She notices it more so of doing like upper body type exercises, like that she gets like gripping, like in the pecs. And then when that happens, sometimes she'll get like radiating pain going down her arm. And it doesn't happen all the time, but it seems to be like doing things like if we're trying to strengthen like serratus anterior or rotator cuff, things where I'm not trying to have her work on pec strength, but it seems to be like on that one side, she's very like, that's where it goes. Like it goes a lot into the pecs, and then we'll get like tingling going down the arm. And I'm not sure if that's related to the implant, since it started happening after the surgery, or if it's just like a coincidence and it's like a different shoulder issue.
So are her implants under the muscle?
Yes.
I mean, you're sort of describing a classic, again, with all the disclaimers, right? I haven't seen her. I'm just trying to put some framework around this. But you're describing a situation that's dependent on muscular contraction,
Mm-hmm.
which would be classic for submuscular implants.
Mm-hmm. Okay. And so is there anything I should avoid or do with her that could be, it's not like having her do exercises is going to make any like permanent damage or anything to that. It's just because there's an implant under the muscle.
Yeah. I mean, like I said, I can't imagine, with one more time with all the disclaimers.
Yeah.
I can't imagine a protocol that you would use that would cause a surgical exacerbation.
Mm-hmm. Okay. And so it doesn't necessarily mean like she has capsular contracture or anything. It's just because there's pressure under the pectoralis.
Yeah. And so, first of all, capsular contracture is so common that you always kind of just as a, if nothing else, to check the box. If the implant feels really firm, then that's capsular contracture. It's nothing else does that.
And that can cause pain.
And whether it doesn't fit exactly the description that you're kind of putting forth, that is, it's associated with muscle contraction. Usually capsular contracture is more around the clock. But you always rule it out just because it's such a common cause of discomfort. But if it's not firm, then, and if it's really affecting her quality of life, she might consider either removal or going over the muscle. And I will say this, I think there was a question in the chat like that was kind of asking how much does that actually help once the muscle has already been transected, how much does it help to go over it rather than under it? And this is just my own experience. It was dramatic, just like from significant pain to no pain. There was one study that was published a few years ago that suggested that this is exact, probably you have to wonder if it's okay to say things like this today, but there was a study that was published that suggested that 60% of women with submuscular implants had pain at 2 years, which is to say that if men had submuscular implants, we would not survive.
Thank you. So it does look like there are a couple more things in the chat, and I think Mary Kay still on the call, so that's great. And this question says, can you discuss what mobility issues or limitations arise from subpectoral implants related to cosmetic surgery, and whether any of those mobility problems can be overcome post-explant and pectoral repair?
So I think we can certainly see shoulder dysfunction that just starts with pain. And pain causes hesitation, hesitation causes stiffness, and it kind of becomes one of those self-perpetuating cycles. And that's where I do feel there is a role for physical therapy intervention to try to recover the range of motion and, as we said before, sort of the empowerment of being in control. Whether that will resolve the first domino that fell, which was the pain, is a slightly different question. And as I said before, oftentimes you have to remove the implant or put it over the muscle to do that. But I don't see any limitations, and I do see a role for trying to recover whatever muscle limitation has occurred as a result of that.
Thank you. Kotz added a couple of minutes ago, I think this was related to Lisa's question and your comments about timing and like post-op to PT timing and the how comes. And it says it's because it takes months first you receive expanders and expand them for weeks before the implants are put in. So I just wanted to add that. And then Maria asks, can you talk about sorry, where did it go? The DIEP flap side effects and risks?
Yeah, I mean, obviously a completely different story, right? I'm just looking at the expander note real quick. And part of that obviously would be, what about after the second stage where you go from expander to implant, and when would you see that patient? So yeah, I mean, the deep flap is really a completely different category, right? This is transferring tummy tuck tissue to the chest. It's a big procedure with about a 30% complication rate, and but it is the go-to procedure to try to achieve breast reconstruction when either implants aren't possible or the patient doesn't want implants. Are there any kind of more specific questions you want to go over about the deep flap?
Yeah, I was wondering about abdominal restriction afterwards, or any kind of side effects on the arteries, veins.
So again, all of this is timing related. It's like, as a general rule, by 6 months after surgery, things are pretty bulletproof, which isn't to say you can't do something extreme. But if just me again, if I had a patient who was 6 weeks out from a deep flap, then my protocol is whatever is comfortable, whatever they can tolerate, and probably a little more.
Mm-hmm.
Now, in terms of the artery and vein, again, by 6 weeks, all of the vessels have completely re-endothelialized. If the only thing that could cause a problem is like some weird, continuous, focused pressure, or just extremely bad luck. But it's hard. I can't think of a physical therapy maneuver, a typical physical therapy maneuver that would be problematic after that post-operative period.
I have a question, and then it looks like there's a new message. I have a case where I'm working with someone who had a breast reduction and a tummy tuck, and she has had pretty significant decreased sensation in her abdomen from the tummy tuck. Is that something that is common with breast reduction or removal, or is that really more straightforward?
So if you're describing the loss of sensation in the lower abdomen, that's really typical. In order to I'm going to use some technical terms here, but in order to sort of lift the flap up so you can pull it down, you often have to transect some of the nerves that give sensation to that tissue. In later years, surgeons have become much more careful about trying to preserve nerves and vessels. It used to be kind of this really wide, aggressive dissection, and that's no longer the state of the art. But it's still very typical to have some sensory loss in the lower abdomen. It wouldn't be related to the breast reduction. That might cause loss of sensation in the breast, but it shouldn't have an impact on the lower abdomen.
Thank you. And Maria says thank you in the chat. Are there any more questions? I see Chris, I see your hand up, and then Zeina.
Yeah, I have a question about the deep flap versus doing a prepectoral implant or prepectoral implant. What would be the reasons you might choose the deep flap over the prepectoral? And then what are some of the complications? I have a client who's choosing between the two. What are some of the complications that come with the deep flap or both actually?
How much time do you have?
Little question.
Yeah. I mean, the most common reason for a deep flap is someone who's already had radiation and tissue that's just not going to tolerate an implant. The second most common reason is just patients who don't want implants. Although insurance companies are starting to raise their heads about that because the deep flap, especially bilateral deep flap, is such an expensive procedure. But you know, the single biggest risk of a deep flap is that it will fail. You know, you're talking about hooking arteries and veins that you can barely see with the naked eye. And even though I said that it's relatively bulletproof at 6 weeks, it's a miracle that it works at 6 hours. And so the thing that we worry about the most is that flow will stop, and it can stop for all kinds of different reasons. And yes, sometimes you can recover flow by going back to the operating room, but it's pretty devastating to go through a procedure like that, have a deep flap, and then have the flap actually fail. And you know, that's my hesitation around the deep flap. But in patients for whom implants aren't a possibility, it's a little miracle. You know, about a 95% success rate, but you know, 5% isn't particularly a relief if you're one of those 5.
Thank you.
Yeah.
Are there any more questions? Lane?
Yeah, I can't find my raise hand thing. It says, okay.
Okay.
Anyway, I have a client who had a breast reduction and has a lingering infection at the site of the wound where she has to wear a vacuum pump for it. And my concern about after she's got to be approved, of course, for PT, but when she comes back, are we concerned about further scarring because of that infection and how slowly it's cleared? Is the tissue going to be different at that site that I need to kind of worry about stretching or something that I can't imagine what from that?
You know, there have been so many questions about this restricted motion in therapy that it's probably worth just taking a step backwards and saying, you know, when is there actually a surgical restriction versus just what a patient can perform? And as I said earlier on, I can't think of a lot of situations where, other than in the immediate postoperative period, which we could let's give that even a relatively broad range, 0 to 6 weeks. I can't think of a situation after 6 weeks where the surgical procedure is the limiting factor. Now, with a VAC and an open wound, you're probably going to have more, yes, as you alluded, more scarring, more indurated tissue, probably more challenge in getting that to loosen up. But it's the patient's capabilities, not the surgical procedure, that is the limiting factor. And I think just in general, to sort of emphasize this point, and with one more time saying this is just me, this isn't that patient's surgeon, I can't think of a real surgical restriction after 6 weeks unless there was, you know, something really unusual.
Thank you.
Thank you. And in the chat, Suzanne says there's so many other flaps. What about those?
Yeah, I don't know if that's.
I'm sorry that I know that's such a big question. It's just that, I read more and more about these like gluteal, adductor flaps and things like that. It just boggles my mind. But, because it's a long way to go.
It is a long way to go. And you usually go there when there's nowhere else to go.
Okay.
The deep flap, a bilateral deep flap can be a 12 to 14-hour procedure.
I believe it.
And gluteal flaps are even longer, and adductor flap. It's like, the tissue that is the most soft and similar to breast tissue is the deep flap. So every other flap is a bit of a retreat from the goal of trying to get as close to normal as possible. But when there's, like, if someone's had a tummy tuck and then they develop breast cancer and have a mastectomy, obviously you can't do a deep flap anymore, and so you do what you can.
Well, thank you.
And again, generally speaking, the biggest risk is flap failure.
Mm. Yeah.
Thank you.
Thank you.
Anyway, I will mention, one of the workhorses in breast reconstruction is the latissimus flap, which is the big muscle from the back and the overlying skin. And this has always intrigued me. This is just me being a little bit contrarian, but I actually find that flap to be a little, I hope I'm not going to insult anybody on the call. It's quite a donor site cost. In other words, the area where you take the latissimus from can look pretty different. And so you get some benefit on the chest, but you get quite a deficit on the back. And so some surgeons try to do partial latissimus flaps, which are obviously better. But of all the flaps that I think are common, the total latissimus flap is one that I personally have had the most trouble thinking of as a go-to flap. I think it's a long discussion of what the pros and cons are when you're talking about a total latissimus flap.
Thank you. In the chat, Lisa asks, are there any special considerations for people going through gender transition that we could know about? And I would just like to add on if there are any specifics regarding FTM versus MTF.
So let's try to focus this just to chest surgery. And
yeah,
for what has been called female to male, I think it's important to point out there is no involvement of the muscles at all in typical female to male gender surgery for TOPS. For quote unquote male to female, which is probably getting to be old language just for the sake of it, because nowadays, rather than putting a label on it, you just sort of ask people what their surgical goals are. So let's say for breast enlargement or breast creation, then it's the same questions as we talked about before. Is it under the muscle? Is it over the muscle? Is it a neuroma versus, is it round the clock pain versus exertion type pain? All of that is pretty much the same.
Thank you. And then Maria says that was my next question about lap flap. And so Maria, are you still interested in hearing more about that, or was it satisfactory, the talk that we had about it so far?
Yeah, if Dr. Jacobs can talk a little bit more about it, that would be very interesting for me.
About the latissimus flap?
Yes.
Mhm.
Anything in particular you're curious about?
Yeah, actually, I'm having reconstruction next year and trying to decide between lat flap and DF flap. And I'm being told that I don't have enough fat on my belly to do a DF flap. So most of the surgeons that I saw, they are, they think the best option is the lat flap, but I really don't want to touch the latissimus dorsi.
So Maria, I'll tell you, I always hesitate to do sort of telephone or Zoom medicine. So I'm going to sort of try to put this into a broad context rather than a specific one. I think even in the absence of fat in the abdomen, sometimes you can do a deep flap and an implant so that you get the coverage and the volume. The latissimus flap, I need to be candid. Most people do very well with latissimus flaps. I just personally find the donor site aesthetics to be maybe under discussed, is probably the best way to put it, that it's such a reliable flap that's one of the reasons why surgeons tend to use it frequently. It doesn't have the 5% failure rate that a deep flap has. But it's a scar on the back. It's a sort of a contour deformity on the back. It's amazing that you can transfer this huge muscle and have almost no shoulder dysfunction, which has blown me away since I was a resident. But those are the conversations to have, I think, with your surgeon. Is if your goal is a certain aesthetic, then the beauty of a deep flap is the donor site is a tummy tuck, whereas with a latissimus flap, the donor site deficit is a real deficit.
Yeah. Gina, yeah, thank you. I think we have 4 minutes left. So first of all, I wanted to do a little wrap up, and thank you so much, Dr. Jacobs, for being here with us, for sharing all your information. It is such an honor to be able to have you here, and so helpful for us. So we are really very grateful. I just wanted to throw out, if you guys have more questions about what's going on, please just send me an email. I'm happy to dig up answers for you, and see what we can do to get answers. And I can, maybe if you're up for it, Dr. Jacobs, send you a message if we have some interesting questions we can't answer, and see if you want to give us a little input. But I also wanted to let you know that in 2 weeks' time, we'll revisit the topic, but what we'll do is Pilates specific exercises for different situations that might arise. So we can talk about frozen shoulder and exercises related. We can talk about range of motion for the pec muscles. We can talk about rehabilitation for the abdominal muscles as well post, and we'll do some lecture demonstrations. So that would be on August 30th at the same time. If you're interested, you can let us know, send us an email. We'll send you the link for the meeting. And then that's about it. So I really appreciate you guys all being here. Yeah.